So this is I'm Dr. Talin Pepper, and we're here with Dr. Bradley Miner, and he is a local orthopedic surgeon in our region. And so I was going to sit down and talk to him about some questions that people have for me. And so first off, just tell me a little bit about you. So where did you go to school? Tell me about family.
I'm from here in Fort Worth. I went to TCU in Fort Worth for undergrad, and then did my orthopedic training at UT Southwestern in Dallas, and then a further fellowship in hip and knee replacement at Joint Implant Surgeons in Columbus, Ohio.
Okay.
And then moved back here shortly after that, and been here ever since.
Nice.
Yeah.
Nice. Very good. So Chisholm Trail is, they've kind of expanded, growing a little bit.
So our practice here is Chisholm Trail Orthopedics and Sports Medicine. We have offices in Cleburne and Fort Worth, and now second Fort Worth office is opening up as well. So we're expanding. There's two other orthopedic surgeons that are more sports medicine focused, and then two podiatrists as well in our group. So
nice. I saw that you brought in a new podiatrist recently.
So it's going great. Going great.
Awesome. So business going well. That's excellent. Well, good to hear. So I wanted to delve into a couple of things. We're going to talk a little bit about some hip things, and then also some knee things about replacements. So the replacements are your specialty, right?
Yeah.
And so we want to kind of discuss with you of what are the trends, what are you seeing? So one of the first questions I have is all patients who have hip pain, they want to know, okay, when is it time to go have this knee replacement or the hip replacement? Like, what do you tell them?
So I think the first step is to get X-rays and see how bad the hip is on X-ray. And then I typically will talk to the patient, and you're mostly going to be doing a replacement on someone who has bone-on-bone or end-stage arthritis. In some cases, you can do it in slightly less severe arthritis, but that's kind of one of the main criteria is, we get the X-rays, make sure that that's what is going on and that's the right surgery, because some people will have, knee pain for other reasons than arthritis. Then once we know that you have arthritis, there's a couple of different options. The conservative treatment is what people usually start with, and that's going to consist mostly of things like different types of injections, so steroid injection, delayed release steroid, hyaluronic acid injections, stuff like that. And then activity modification, weight loss in some patients, occasionally bracing, unloader braces, stuff like that. That's all the conservative management. And then typically, when to decide on surgery, people usually have tried an injection, something like that. And if it's working for them and they're feeling great for 6 months, well, you can keep doing those injections as long as you want. Eventually, usually they'll stop working, and they'll start lasting a shorter and shorter period of time. Usually I say that if it lasts for 3 months or more, that's considered a successful injection, because that's when you can repeat it, typically. And so if they want to keep going with injections and they're getting good relief, there's no necessarily, you don't ever have to have a joint replacement. It's just when it's affecting your quality of life enough that it's worth having a major surgery for. So eventually you're going to be not having good enough relief, and you're going to have too much pain in between that it affects your quality of life. And when that happens, that's time to pull the trigger on a joint replacement.
So they can't kneel, they can't squat, they even with their kids, they're seeing like same.
And it varies for everyone. So if you can't do the things that you want to do in your daily life because you're having pain from arthritis and it's affecting your quality of life significantly, whether that's you want to be playing golf or you just want to be walking around the grocery store, it's different for every patient. But I think when you decide this is really affecting my quality of life on a daily basis, it's worth having a joint replacement.
Right. And even you'd say for maybe even younger, like I can kind of think of a case in my head now. It's like she can't kneel, she can't get down, she wants to be able to be more active with her kids, and
so I actually do joint replacements in younger patients pretty frequently, and younger for a joint replacement is under 65. So patients in their 50s, patients in their 40s, if they have bone-on-bone arthritis for whatever reason, whether they just happen to get arthritis early and have bad luck, or in many cases they've had some sort of trauma or previous surgery.
Right.
That's who we see a lot of that are younger age, that people used to say, oh, you're too young for a knee replacement, you're too young for a hip replacement. We don't really say that anymore. If you have bone-on-bone arthritis and it's significantly affecting your quality of life, I think, your age really is somewhat irrelevant, although the longer you have a joint replacement in, the higher chance you have of having it redone. But there's no reason to suffer for more years just because you're younger than the average patient anymore. Sure. The plastic that we use now, so the polyethylene liner on the hips and knees, it wears a lot slower than it used to. So everybody will come in saying they've heard, oh, it's only going to last 10 years, something like that. Mm-hmm. That's not necessarily the case. I usually cite a 1% revision rate per year for joint replacement. So in the first year, there's a 1% chance that something will go wrong. That'd be some sort of complication like an infection. If you have it in for 20 years, there's a 20% chance. So it's not necessarily like they wear out at a certain time point anymore.
Right. And even with maybe activities, right? So like want to play pickleball, or they want to go, try to jog, like you said, some of these people can
so I think different surgeries, you can expect different things. So for a hip replacement, hip replacements will function very close to a native hip. You can do very well and do almost any activity after a hip replacement. Although, if you're doing some sort of, like I had a guy who wanted to do water ski jumping, I'd discourage something like that, because if you had a fracture around the implant, that would be a problem. But any normal activity you would want to be doing is going to be okay. And then the other two major procedures that I do are total knee replacements and partial knee replacements. So in younger patients, a lot of times if they've had maybe their medial meniscus had an injury and they had surgery on that, maybe 10 years later, if they lost a large portion of their meniscus, they'll get medial arthritis, so arthritis on the inside of their knee only. Mm-hmm. And for those patients, I'll do a partial knee replacement, where we leave all their ligaments alone. We leave the outside and the patellofemoral joint alone, and just replace the inside of the knee. You can resume pretty high level activity with a partial knee replacement, and it can feel pretty natural. So pickleball and jogging would be definitely doable. Total knee replacement, you can still do a ton of activity also, but it's probably the one that it would be the hardest to resume really high level activity with. So if you are a long distance runner or something like that, or you're trying to do really high speed cutting, like basketball and, even pickleball, stuff like that. You could play pickleball, but it's going to be a little bit harder with a knee replacement, whereas with a hip or a partial, you're going to be more good to go. And that's not saying that you can't do most anything with a knee replacement as well. But really high demand sports are going to be harder with a knee replacement in general.
Sure. Yeah, I could see that for sure. So now I want to just circle back a little bit to the hip replacement. You said overall it's more like a native hip. What are you seeing with, some people ask about, an anterior hip versus a posterior hip.
Yeah.
What's the difference? Why might you recommend one versus the other?
Well, so anterior and posterior, and then direct lateral, less so, are kind of the most common approaches in hip replacement. Posterior is the most common. Anterior has become much more popular recently. I do all anterior hips, so just upfront disclaimer, I may be a little bit biased. So
okay, really well. I know they've been doing great.
I definitely am a little bit biased towards it, but the difference is, so the way you enter the joint on a posterior hip, you're going to basically split through the gluteus maximus fascia and then up into the muscle too, and then you detach these muscles called your short external rotators and then repair them at the end. That's a perfectly fine way of doing a hip replacement, and depending on who you talk to, they're going to say it either does just as well or there's no difference. But On an anterior hip, you basically go in between the muscle, and so you don't cut any of the muscle. It makes it more technically challenging than a posterior hip, so there's more of a learning curve. You don't want to do an anterior hip with someone who doesn't do many or hasn't done many in the past. But the advantages of it are, depending on the study you look at, a little bit faster recovery. And then there's some other technical advantages. So depending on the study you look at, in many studies there's a higher dislocation rate with a posterior approach hip. The dislocation rate is extremely low in an anterior approach hip. There are other downsides of it. There's a high risk of intraoperative fracture with an anterior hip. That's mostly surgeons in the learning curve that are having that issue, but that definitely is cited in the literature. And then the dislocation issue plays into what we call hip precautions in the post-op period. Not all posterior approach surgeons will have hip precautions, and that's things like not being able to sit in a low chair or cross your legs and stuff like that. Not all posterior approach surgeons require those, but many do, and you definitely don't need those with an anterior approach because the likelihood of dislocating an anterior hip is extraordinarily low.
Don't go that direction.
Yeah, I mean, they dislocate out the back typically. Right. And so when you go in through the front, the dislocation rate is extraordinarily low. Another advantage technically to doing it is it's the way I do an anterior hip. There's kind of two ways you can do it. You can use a special table called a HANA table or a fracture table, or you can do it with a regular table and a trained assistant who manipulates the leg for you, which is what I do. And so doing it that way, you basically have both of the legs that you can look at during surgery, and you're laying on your back flat. So it's really easy to measure the patient's leg length, which historically, that's been a problem that patients have had is leg length.
As a PT, I put a lot of, exactly. Wheel lifts and trying to figure out how to walk because the leg's short.
And the reason for that is because the patient with a posterior approach or a lateral approach is laying on their side. And so the way you're checking their leg length is by kind of measuring their knees, but they're kind of tilting forward and back. So there's a lot more variability than a patient laying on their back and you're holding both legs in your hand, measuring them, easily. So there's some technical advantages to it too, but there definitely is a learning curve. So that's why it's not been universally adopted. So if I had come straight out of residency without doing an extra year of training, I wouldn't be able to do anterior hips because I wouldn't have learned how to do that. And many surgeons never did. So, you could go to a course or something like that, but it's not.
You want the resident.
Yeah,
they're right there.
It's better to have done a year of training on it for sure.
Sure.
Not to say that you can't do a good job if that's not the case, but it's just a little bit harder.
Right.
Basically.
Very true. Very true. Now, so we talked about that. We'll skip that one time-wise. Let's see. I get this. Patient, they get concerned. They bump their knee into the hall or doorway or whatever. They slip and they fall. They're super concerned. They're like, about, did I damage it? Did I break it? What would it? How strong is that? Like, what would it take to?
Well, so the implants, they're made out of metal, and so they're very strong. I mean, you couldn't physically break them if you tried. They're pretty much impossible to break the implant itself. You could break the bone around it. So if you fell and then you could not walk afterwards, you could have what we call a periprosthetic fracture or fracture near your implant. But you would know, you wouldn't be able to stand up and walk. And then, if it's a recent surgery, you worry about like busting open the incision or something like that, but you're going to be able to see that typically. So if you say a patient is 6 months out from surgery, they've healed, they've recovered, they slip and fall, they bang their knee, hard on something, extraordinarily unlikely that they would damage the implant. You could damage other things. You could, break the bone above it. You could,
Or muscular
yeah, or you could
tendon,
strain the tear a ligament, something like that. But you're very unlikely to actually damage the implant.
Okay.
So typically, if you have a fall like that, if you can't walk, you should go to the emergency room. You may have a fracture or a broken bone around it. If you can walk and it's just really sore, I'd probably wait overnight, ice it, take some Aleve or ibuprofen if you can tolerate it, and don't have any contraindications. See how it does in the morning. If you're still having a lot of pain, definitely feel free to see your surgeon that did your surgery, and we'll take an x-ray for peace of mind, make sure it looks okay, give you reassurance. It almost never is something bad, but occasionally it is. I mean, I had a patient who, they fell and tore their MCL, basically. That's very rare, but it's possible. So, I mean, if it's pretty severely painful, it's not unreasonable to go get it checked out.
Sure.
But usually it's going to be just fine. And the force that it takes to damage the knee after a knee replacement or the hip after a hip replacement is a very high level of force. So it's not like if you fall and bump it, it's going to break. It's pretty much just as strong as it was before.
Yeah.
So it would take something like a car crash or a really big fall, something like that, to damage it.
Gotcha. No, that makes sense. So, yeah, essentially, talk to your professional. I mean, if you're seeing a physical therapist, which usually you would be for the most part at these, and talk to them, check with them, and then be in contact with your surgeon on what to do
for sure.
with it. Yeah, absolutely. And that's good advice for them. So I want to circle back one last question. I know I've got patients that want to ask about it. You mentioned the posterior hip where they go in and they detach these external rotators. They have to go through and split the fascia. So these people, sometimes I see, but they limp, they have some problems with it. It can be pretty debilitating over time. So have you seen anything with being able to repair those? Like, do you know anything about that situation?
So what I've seen with, repairing muscles after a hip replacement, the third type of approach is the direct lateral approach, where you actually split the abductor muscles. So that is like this motion, spreading your leg apart. Sure. I mean, you know this, but
these are abductors.
But, so you can see abductor repair because that approach, you basically split through those abductor muscles and then you reattach them at the end. And you sometimes will go back in and see those completely torn off. And that'll cause a limp. So, if that happens, it's a problem. You can reattach them, but it is likely to re-tear again in the future. With the posterior approach, you could tear, those short external rotators, tear that repair. Those muscles, that's going to lead to less stability of the hip, so a higher dislocation rate, and could potentially cause a limp, but less so than if you had an abductor tear, like on a lateral approach. We do see abductor tears are becoming more talked about, especially in the sports medicine literature, which is sort of a different subspecialty from mine. But we do see patients who've torn their abductors, and typically we're going to start with things like injections and physical therapy, but you'll have patients who continue to limp, continue to have issues with it, and then oftentimes we'll get an MRI that shows a tear. And then in certain candidates, certain people who are good candidates for it, I'll typically refer them to a sports medicine specialist that does hip arthroscopy, because you can do an abductor repair through a scope. It's not a super common procedure, but it's sort of kind of an up-and-coming thing.
Sure, and becoming more popular. Literature review is working through it. It's like I see more and more that I see like kind of younger age, like trying to prevent, almost like they did a lot with the rotator cuff repairs. They'd go in and say, hey, to try to prevent you from having some of this, we're going to go in and fix your supraspinatus. Well, it's kind of almost the same thing if those are the rotator cuff of the hip.
Exactly, and people call it the rotator cuff of the hip. Right. So, that may be something that becomes more common in the future as that becomes tested and things like
Fields
that.
advancing. It's still kind of in its early stages of doing these repairs.
Yeah,
How they hold, who's the right candidate, right?
Yeah.
The older candidate who doesn't really have the capability to hold in, the bone integrity, the tissue integrity is not holding. They're more
And it's more likely to be a younger patient, things like that. So, yeah, I mean, I think that could be something up and coming in the future for sure.
Absolutely. Well, I know we're running out of time, so I really appreciate your time.
No problem.
And good to
good to see you.
Good to see you. This again if I got some more questions.
For sure.
So,
for sure.
So if you need a good hip surgeon, right here we got Dr. Miner. He'll take care of you. And so I really appreciate your time.
No problem. Thanks a lot.